We'll get started, 7:01. So good morning, everyone. Welcome to our talk for the ground rounds today. I'll be giving a presentation on sacral neuromodulation and neurogenic bladder. I figured this is something I do on a regular basis, and it's poorly understood why we do it or how we came about doing it, and why we do apply it in some cases and not in others. So this is just going to be a general overview, kind of showing you the reasons we do certain things pertaining to sacral neuromodulation. So I'm going to start by saying I don't have any disclosures. This is going to be the outline of the lecture today. We'll start with definitions. We'll review some brief physiology of micturition. We'll also talk about the history of sacral neuromodulation's mechanism of action. We're going to look at clinical outcomes based on non-neurogenic population, talk about the neurogenic bladder and manifestations of neurogenic bladder as well, and also look at outcomes of sacral neuromodulation and PTNS for neurogenic bladder. I will briefly go over current research that's in the pipeline and future directions as well. If my voice is not very clear, you have to excuse me. I'm starting to get hoarse from cheering for my kids' games on Friday. All right, so quick definitions. Neuromodulation is the manipulation of spinal cord reflexes and brain networks with electrical energy, and they do this via the peripheral nerves, which are easily accessible. The goal is to achieve a desired outcome, which is predefined, either less, inadvertent micturition, better storage, and or possibly less fecal incontinence as well. So you have to predefine your outcome. Neurogenic bladder is dysfunction of the urinary bladder secondary to diseases of the nervous system. It results in problems with storage or micturition, or oftentimes both storage and micturition at the same time, as in the entity of detrusor overactivity with impaired contractility. Before looking at, micturition, we should know a little bit about neurourology. There are certain key players that as residents we need to be familiar with, or we needed to be familiar with. The sympathetic nervous system is primarily controlled by the T10 to L2 nerves, which are the thoracolumbar nerves or the hypogastric nerves also. They primarily are related to continence and storage function of the bladder. The peripheral nervous systems supplied by the sacral nerve, which are derived from the S2 and S4 roots, are also tasked with bladder emptying, so which is the opposite of the thoracolumbar nerves or the hypogastric nerves. There are certain primitive reflexes, which are triggers for events within the cord that don't require higher level control from the micturition center. These are the Garden and micturition reflex. Basically, they're afferents that are supplied from the spinal cord directly to the bladder, and that can either lead to Garden or micturition, depending on the situation. So, for instance, if someone is coughing or they have increased abdominal pressure from being punched in the gut or something, there's a reflex that's triggered that automatically, the somatic reflex that causes the sphincter to contract to prevent leakage. And then, with the micturition reflex, that's what we target with sacral nerve stimulation because it is uncontrolled in overactive bladder. Then you have your higher brain centers, the brainstem, the pons micturition center, and the central nervous system. These are responsible for your voluntary control and initiate or inhibit voiding. And often you see this in stroke victims. Loss of supraspinal control can result in unmasking of the primitive reflexes. So a typical stroke victim after the initial shock period will have detrusor overactivity and automatic voiding with filling. Just a schematic of the nerves that are involved again, just for your viewing here. The sympathetic nerves you can see coming from L2, but they're primarily derived everywhere from T10 to L2, supply the bladder and the internal sphincter. You have your parasympathetic nerves also from the sacral nerves. They primarily supply the bladder, and then your pudendal nerve, which are under somatic control, and they control your external sphincter. And these are the receptors on which to act on. So this is important for administration of medications. Your M3 receptors controlled by your pelvic nerves, parasympathetic. They lead to contraction when active or activated. You have your hypogastric nerves from the sympathetic process, and they lead to they promote relaxation via the beta-3 receptor. So mirabegron primarily acts this way on this receptor, and your anticholinergics act on the M3, M2 receptors, but mostly M3. You have alpha-1 control here also from the sympathetic into the internal sphincter or bladder neck in women. And this will promote contraction of the sphincter. So that way there's continence. And then pudendal nerve under somatic control for the external sphincter. This is primarily nicotinic receptor. And so that is controlled by higher brain centers. Just to kind of overview of how the whole process works. When I was studying this in residency, this was a very busy slide. So I kind of came up with like a flow chart of how things actually happen. You have, when the bladder is underdistended, you have slow filling, and the nerve impulses are slow impulses. So there are different type of impulses that are transmitted by the efferent fibers. The afferent fibers. And so when they get to the midbrain center, or the pons, it recognizes these impulses as, the bladder is still not distended. And so the parasympathetics are inhibited, and this leads to a lack of contraction of the M3 by the M3 pathway. It also transmits directly to the thoracolumbar plexus, and you have stimulation of sympathetic fibers. And so that stimulation leads to relaxation via the beta-3, which I went over before, and alpha-1 stimulation at the same time. So the end goal is storage, because as you can see, where the receptors are acting on the beta-3 and the alpha-1 leads to storage. And then this is inhibited, the parasympathetic, and that leads to, also promotes storage. And the opposite happens here. With a full bladder, the nerve impulses are faster. The midbrain and the pons recognizes the signal as it's almost time to go, and then it inhibits the sympathetic fibers. So there's no relaxation. The beta-3 is blocked. The bladder is no longer relaxed. Alpha-1 is no longer stimulated, so there's relaxation of the sphincter, internal sphincter. And then the pudendal is inhibited, and that leads to relaxation of the external sphincter as well. And then with the parasympathetic kicking into gear, you have stimulation of M3, which leads to contraction, and then the end result is emptying. So all these lines kind of demonstrate what the flow chart is showing you there. So in terms of the history of sacral neuromodulation, prior to 1960, most of the research focused on direct electrical stimulation of the bladder, but the amount of energy needed would often cause damage or injury to the bladder. And so this was abandoned. Back in 1972, a fellow by the name Giles Brindley developed anterior sacral root stimulators, primarily used in paraplegic patients. And for reasons I'll later explain, he combined this with posterior rhizotomy of the S2 to S4. And the goal was to abolish the voiding reflex that was transmitted by the posterior sacral roots. Does anyone know who this Giles Brindley is? He's very famous in the urology world, especially in the ED world. So maybe this will clue you into what he did. So what happened in Dr. Brindley's pants didn't stay in Dr. Brindley's pants. At the 1983 Vegas conference, he brought a whole new meaning to the word exhibition. Yeah, so if you know the famous story of a urologist who went to the AUA and showed his erection as a result of phenethylamine injection, that's Brindley. So I was looking into him, and he's actually not a urologist. He's a physiologist, a very intelligent guy, and a musical composer. So he did a lot of work in sacral neuromodulation as well as in the ophthalmology world. So moving on, what he did was basically his procedure requires a laminectomy and intradural placement of a electrical stimulator. This process was irreversible. The rhizotomy, which was cutting off the posterior sacral roots, affected sexual function. And obviously, whenever you mess with the dura, you worry about CSF leaks. So that was another issue with that. However, the end result was very successful in select patients, especially people with spinal cord injury, stable spinal cord injury patients. Once active, they were able to void on their own or have bowel movements on their own by directly stimulating those nerves. However, because of the morbidity of the procedure, it's not really suitable for the masses. So this is sort of a cartoon showing you exactly where, so this is the posterior roots. So the rhizotomy is on the posterior roots, and that is because this afferents transmit, they go back to the spinal cord and they kick in the micturition reflex, and then these patients void and then have DO and they void. So even though they're able to void volitionally, when they stimulate the anterior roots, they leak in between. And so the posterior rhizotomy was a necessary part of this procedure. And that way they remained continent, but were able to void on their own by stimulating the anterior roots. So overall, they found they were able to eliminate reflex bladder contraction. They were able to improve capacity and reduce DSD as well. This is just a picture of what the rhizotomy is like. They've done the laminectomy. They're selecting the posterior sacral roots to cut. So as you can see, it's a very involved procedure, detailed procedure. Not a lot of centers do this. There are very few in the US and maybe more in Europe. So here you can see the electrical leads are implanted intradurally and then connected subcutaneously. And then you have the box, controller box that's provided to the patient, which they use to control, to micturate. So while Brindley was doing this, other people looked at, basically minimizing the morbidity. In 1982, sacral nerve stimulation was performed by Tanago in the first described literature of this. He used improved leads with tines. They noted that sphincter contraction abolished the trusor activity through some kind of inhibition or inhibition reflex. They demonstrated that modulation of sacral nerve stimulates sphincter and stops the trusor reflex voiding through that same pathway. And 1 year later, McGuire introduced posterior tibial nerve stimulation. Currently on the market, there's several, there's actually only two big players. The main one is InterStim, that's owned by Medtronic, which is the giant. Axonics is a new company, new kid on the block, and that's pretty much it. For posterior tibial nerve stimulation, same thing. Urgent PC was the original. Medtronic came up with their own called the Neuro. And their experimental procedures involving either of these ones, like a dorsal genital nerve stimulation or pudendal nerve stimulation. So since InterStim is primarily what I use and what was the first one, I'll mostly focus on the InterStim. It was FDA approved in '97. This was based on the sacral neuromodulation model from Tanago. It involves stimulation of sacral spinal roots with an implantable lead, and it was connected to the generator device. And this resulted in an alteration of bladder function. The main indications right now are urinary retention, urge incontinence, urinary urgency and frequency, and fecal incontinence, which came later. During the approval study, safety and efficacy were not established in pregnant patients, pediatric patients, neurogenic or neurogenic bladder. The thinking was you needed an intact spinal cord or intact communication for this to be efficacious, but that has since been proved wrong. Pediatric patients for obvious reasons, pregnant patients for obvious reasons, but we do use it in all patients except obviously pregnant patients. We can wait until after delivery. It is a two-stage procedure. The goal is to locate the S3 nerves, S3 foramen, to put the electrical lead right alongside the S3 nerve roots and to stimulate its nerve roots. There are two-stage procedures, like I said. One of the variations in the first stage is the peripheral nerve evaluation, or the true first stage. The PNE is modified by using a temporary lead. So this temporary lead is not the actual one used permanently. And that gives us an advantage of being able to do it in the office or under some minimal anesthesia. You can also pull out the temporary leads easily in the office as well. And that's also one of the disadvantages of the PNE, because there's a lot of migration. When the patients move around or mess with their dressing, it gets out of the foramen and they lose stimulation. The first stage uses the permanent lead, which is eventually implanted, but is kept separate from the pocket. And so they're given a chance of 1 week to 3 weeks to test it out. The action that's wanted or seen in the operating room is to confirm that it's in the proper foramen is a bellows, or which is the pulling of the rectum towards the pulling of the rectum. So you see an inner wink and pulling in of the rectum, and on the foot, on the ipsilateral foot, you should see a flexion of the great toe, and sometimes other toes. If you're in the wrong foramen, S2, you'll have a significant ankle plantar flexion. You will not have any bellows. If you're an S4, you'll have just bellows and nothing else on the foot. And so aided by fluoroscopy as well, these muscular feedback is important to know where you are. Obviously, after the stage 2 involves implantation of the actual pulse generator. The next company that got involved in this market is Axonics. This was first approved in 2019, originally for fecal incontinence, and later expanded to include urgency incontinence, frequency, urinary frequency, and urgency. This was initially marketed as the first rechargeable system, which it was, and the first to be approved as MRI compatible. And this is the rechargeable system where it's attached by Bluetooth to the battery, and then it requires a recharge once a week for about 30 minutes. Shortly after, obviously, Medtronic upped their game and also came up with their own rechargeable system. So the implantable pulse generators these are all that's currently available on the market. This is the current InterStim. The one preceding this was the InterStim 1, which was twice the size and twice the thickness of this one. This is the Axonic IPG. And you can see their profile when put flat. And then Medtronic came up with their own rechargeable system as well, which is the InterStim Micro. So here, the Axonic guys say their system will last in your body for 15 years before it completely discharges or needs to be replaced. The InterStim 2 has a not a shelf life, but once implanted, average lifespan is 5 to 8 years, usually on the lower side, maybe 6 years, 7 years. According to Medtronic data, they've come up with a new, really novel system, which is beyond me because it involves a lot of physics, where the discharge in this battery is basically null. In their rechargeable system, they claim that it can go on forever. You can recharge it several times in infinity, and it doesn't need to be replaced. So that's obviously something that will need to be tested in the real world. So how does it work? Right now, this is all, obviously a strong debate, and there's a lot of research towards this. One of the theories from the original work of Tanago is that direct activation of efferent fibers to the striated muscle, urethral muscle, cause reflexive detrusor relaxation, so the storage reflex. This was primarily how PTNS was developed, because also stimulation of the perineal area also caused somatic muscle contraction, which inhibited detrusor relaxation, which caused detrusor relaxation. So that's how PTNS was also developed, but it doesn't explain how it works in retention. So because obviously in retention, we don't want to cause relaxation of the bladder more. Second theory is that it involves higher order, maybe by primarily actually in the central nervous system, mostly by modulating the signals from the ascending or descending pathways of the micturition reflex. And the way they've shown this is by looking at evoked potential data, functional MRI, as well as animal models, mostly cats and rats as well. So what are the outcomes of sacral neuromodulation? There are a lot of data out there that's shown that it's relatively good outcomes in the non-neurogenic population. And I just cited a few studies here on a table from Nature Reviews. The highlighted ones are the ones with the most long-term follow-up here. Well, obviously very interesting to see the variability here. This one would have follow-up at 5 years, and they had the success rate was down to 68% and 56% for urgency incontinence and urgency or frequency symptoms at 5 years. In this group, it was 15% completely continent, which is not, maybe a more stringent definition for success, because obviously we are looking at 50% improvements, not complete continence. So maybe that's why they have a much lower number. In this one with 50 months, 85% of the patients were reported to be successful. Outcomes and retention, not as great, but pretty good as well. Here you can see at 12 months immediately post-op, the need for greater than 50% reduction in catheterizations in up to 68% of patients. So if they were catheterizing 6-7 times a day, they were down to 2-3 times a day. But at 60 months, it fell down to 48%. And that's generally what we see in the neuromodulation data out there. Most of the adverse events were minor. These are them listed in order of appearance and unreported adverse events. A lot of times when you have revisions, it's mostly because of lead migration or pain at the IPG site, which is intolerable for most patients. Surgical revision was as high as 42%. So bear in mind, at this time, most of this data, it was when the InterStim 2 battery, which is quoted to last 5 to 8 years. So most people at 5 years will need at least one revision to replace the battery. And then you're having a 42% revision rate here, but not for battery replacement, mostly for pain or lead migration. So what's the problem with neurogenic bladder? The main issue with neurogenic bladder is the variability in presentation of disease and where the disease is occurring. And so the problem you have to determine, usually using urodynamics, is a problem an overactive bladder with an underactive sphincter or an underactive bladder with an overactive sphincter. You will, obviously, before you do urodynamics, the location of the lesion is also helpful as well. So what are some of the common neurologic diagnoses that we encounter in urology? Diabetes obviously is very common. Manifests as impaired sensation. There's loss of motor function. In Parkinson's, there's hyperreflexia, overactivity. There's sphincter bradykinesia, a slowed opening, which can lead to retention or incomplete emptying. With cerebrovascular accidents or strokes, there's the acute phase where they have hypocontractility with retention. And then with nerve reorganization, they do get detrusor hyperreflexia and sometimes with a coordinated sphincter. We also see quite a bit of MS in women, and it all depends on the location of the lesion and what the presentation will be. Spinal cord injury obviously depends on the location as well, but they do all experience spinal shock, which is because of hypocontractility. This lasts anywhere from 6 to 12 weeks, but we give it as much as 6 months in some people. And then with nerve reorganization, there's detrusor hyperreflexia, and you often see DSD as well. And that's why they had higher risk for upper tract damage in the spinal cord population. So how have we applied sacral neuromodulation for the neurogenic lower urinary tract disorders? There are no randomized control trials, obviously. There was a big meta-analysis done in 2010, which pooled 26 studies, 357 patients, and the pool success rate was 68% for the test phase, so stage 1. And after they underwent stage 1, 92% was successful with permanent lead. The mean follow-up was not that great. On average, it was 26 months. So the data from this meta-analysis, you see the disease states, a lot of MS, a lot of pelvic surgery. So we're seeing this more and more with, low anterior resection, sometimes with hysterectomies. People do have a neurogenic bladder after that. This disease, I'm not really particularly sure what this was referring to, but possibly people have had a lot of back surgery. And these are the success rates based on each disease process. The lowest was with the myelomeningocele group. And then the forest plot shows basically with the pool data and the success rates, which was pretty good, like I said. Adverse events, pretty similar, pretty common, lead migration, pain at the permanent neuromodulator site, that's a big one. Infection is another big one. So anytime you have an infection, you would have to explant everything, both the lead and the neuromodulator. Malfunction is very low. I haven't seen that, ever. So that's something that's probably been improved on in terms of the device itself, because the device is actually tested before you close incision to make sure everything's working okay. So since 2010 to 20, I looked around, there's been 17 published studies, no systematic review. And the data shows anywhere from 38% to about maybe 86% success rates, and in terms of their implantation rates. Not enough long-term follow-up to show what the actual data was in terms of success several years out. There was a lot of papers that had revision rates in the 50% range as well. No.
So how does that work with insurance coverage?
So it depends on how you code it, because they do have urgency incontinence, they do have fecal incontinence. So if you just put that as your diagnosis, it gets covered. How do we know this works? There's a couple guys, mostly from China, who looked at actual urodynamic changes, as well as changes in reflux in patients that had sacral neuromodulation. This table here shows how the grade of reflux change after implantation in a number of patients. This was a total of 19 patients, I believe, in this study. 10 of them had reflux, significant reflux that was also followed on urodynamics. They had video urodynamics before and after. And you can see significant reduction in the grade from this one example, went from 3 to 1, 3 to 1, 4 to 2. Obviously, there were some that persisted, but slight. I don't know what the risk factors were for lack of success on those ones. Urodynamic tracing before. In this particular patient, patient 1, you can see reflux all the way, probably. And then after implantation, same patients, you can see the sacral nerve stimulator here, right here, and the bladder is pretty much maximally distended, no DO, no reflux. And obviously, these are changes that we expect to see in patients that have had Botox because of the direct action of Botox, but it's encouraging to see, and also through sacral neuromodulation, you can achieve the same results. The spinal bifida population is a little tricky because obviously this is a congenital situation, and the rest are mostly acquired. But there's a paper that looked at ambulatory spinal bifida patients with neurogenic bladder and bowel dysfunction. This was a retrospective review. Follow-up was 41 months on average, plus or minus 33. They had a 72% success rate in terms of improvement of at least one symptom, be it the bowel dysfunction or the bladder dysfunction. They had urodynamic improvement in max capacity and max PTET as well. That was demonstrated. This was the same group out of China. In this group, also, this table shows the reduction in the grade of reflux as well in the spinal bifida patients. I believe A is the micturition frequency. You can see the before is white and the after is in dark. This is the same spinal bifida group. So average went from, looks like maybe 14 here to about 10. This is the average volume of micturition. It goes from about 120 to about 175. This is the degree of urgency from a scale of 0 to 5, went from average of 3 to 2 point something. And also here you can see the residual volume also significantly went down from an average of less than 400 to just under 200. And these are all, again, spinal bifida patients, which is a very difficult population. So how about PTNS? PTNS was approved in 2000, also for the same indications as sacral nerve stimulation, for urinary urgency, frequency, and urge incontinence. The advantages of the PTNS is that it's an office procedure. There is no permanent implant. It requires weekly 30-minute sessions for about 12 weeks. So there's a significant time requirement there. Obviously, if you have your sick patients, really advanced, or patients of advanced age, patients who do not want any implant in them no matter what, this is an ideal alternative. So it works on the tibial nerve, which has mixed sensory and motor neurons, and it does this by with direct contribution to the bladder and pelvic floor. So it modulates the tibial nerve somatic efferents, providing central inhibition of the bladder motor neurons. So this is basically based on the first theory, which is that somatic efferents, when activated, promotes bladder inhibition of contractions. The ORBIT study was a big randomized study that looked at, compared PTNS to tolterodine, which is one of the anticholinergics available. And patients were 79.5% improved compared to tolterodine, which was 54.8%. The SUMMIT trial looked at PTNS versus sham. The number of patients are 220, and there was significant improvement, 54% improved versus a sham. And this is a non-neurogenic population. Let me preface that, because obviously this was for after approval. And Burton had done a meta-analysis with pooled success rates and found success rates between 37 to 82%. So usually the goal is after 12 weeks, you come every month or every other month for a touch-up treatment, but this can be individualized, and in these studies they were standardized. So that's the big difference with a lot of the other studies. How about in neurogenic population, lower urinary tract dysfunction? PTNS has been tried. In this particular study by Cabet, they looked at 29 patients with MS, average age of 47 years, and they had LUTs for at least 4.3 years. They did do urodynamics before and during this, not during the sessions, but during the 12 weeks period. They looked at outcomes, volume at first DO on urodynamics, and it increased from 124.2 to 217.5. They also looked at systematic capacity, and that increased from 199 to 266. And this is just using PTNS alone. Some box plots showing the increase in systematic capacity from this study, baseline versus PTNS. And another one looking at the involuntary contraction, the changes, the first volume baseline, just about 150, and then with PTNS, a little bit over 200. Another study by Gobi also looked at MS patients who were refractory to conservative treatment. And this was a multi-center trial. The patients were all treated with 12 sessions, and they looked at pre and post 3-day frequency volume chart, avoiding diary, patient perception of bladder condition, the King's Health Questionnaire, and urgency bladder. I looked at all of that. And this table shows basically the findings in nocturia improved from 3 to 1 on average, daytime frequency from average of 9 to 6, the residuals from 98 to 43, and also increased voiding volumes, and these are all statistically significant. So that's all the data on mostly in MS patients. There's not a lot in other types of other patients like Parkinson's or stroke or spinal bifida. So currently in development is pudendal nerve stimulation and genital nerve stimulation as well. Just going to go over those real quick. This is mostly for patients that are refractory to standard sacral nerve stimulation. The pudendal nerve, also derived from S1 to S3, which I showed you earlier, is composed of sensory afferents from the pelvic floor muscles and external urethral and anal sphincter, as well as the pelvic organs like the vagina. The optimal level of stimulation is the ischial spine. So if you've done the sacrospinous colpopexy with me, you know where the ischial spine is, and that's the target of your lead. And it can be achieved by targeting the ischial-rectal fossa. There's, I think this is nerve monitoring of the anal sphincter to make sure you're in the right place. A couple papers looked at pudendal nerve stimulation. This one by Spinelli had a limited number of patients, 15, of which about 80% went to chronic implantation because of improvement in urgency, frequency, as well as incontinence. Peters at Michigan, I believe in Beaumont, he had 60. He has the most numbers. 60, he had a less success there. What significant number, 65% went to chronic implantation. These were not studied in the neurogenic population, obviously, but because sacral nerve stimulation is currently, like I said, that's off-label. There is current studies looking at genital nerve stimulation, which could be implanted versus an external lead. And the patient could have control of this by initiating the void or have continuous stimulation. There's been successful on-demand suppression of involuntary detrusor contraction as well as increase in bladder capacity, but these are in mostly animal models. So what lies ahead in terms of the future of neuromodulation? We still have a lot to do to count and adjust for neuroplasticity because we see a drop-off as the years goes on in terms of efficacy. We're not exactly sure why that happens, but it seems the longer you have it, the less it works for the great majority of people that do have a successful implantation. And so with that knowledge, we may be able to adjust for habituation and prevent nerve habituation. And this, we also could think about on-demand neuromodulation to decrease need for lead revisions and battery revisions, because if we are able to turn off the device and only turn it on when we need to, then we might be able to prolong the life of the device. So in conclusion, I think I pretty much covered everything regarding that. PTNS and SNM are effective and should be considered in patients with neurogenic lower urinary tract voiding dysfunction, and it can be safely utilized in this population. One thing I failed to mention in my presentation is, obviously, I think I mentioned it with the Axonics, is they're MRI compatible now, and that's been a concern with this original population, is that they will need MRIs and they couldn't have MRIs. So both the Axonics and Medtronic now have MRI compatible leads, and you can safely implant and not have to worry about explanting it for future MRI studies. There is still quite a bit of research going on, and there's a great need of research and better understanding of neurologic bladder dysfunction, and we need to tailor the treatment effectively. The Brindley procedure started this process, and it's continued with sacral neuromodulation, and who knows, maybe it will end with nerve regeneration. All right, thank you, and I'll take any questions.
Thanks.
Yeah.
You know, this is such a big population when it comes to neurogenic bladder. Specifically, have they looked at either spinal cord and development of renal dysfunction, how you were looking as reflux of the surrogate?
Yeah.
And secondly, have they gone back and actually done any sort of cadaveric studies in people who have had InterStim to see what their overall bladder pathology or histology is afterwards? Because, you know, essentially men or anybody with spinal cord injury can undergo multiple different changes, and that speaks sort of like the longevity of it.
Yeah.
And over time, are they actually affecting remodeling of the bladder? Or
I don't know of any studies that looked at, you know, cadavers in terms of remodeling. That's going to be hard to do. I think you would have to follow these patients for a long time, and then after they're dead, ask for, you know, permission to study their bladders, but just like they do with NFL players with their brains right now. So it's something that you'll have to, you know, follow these patients long term, and a lot of times these patients are not in the same system for a long period of time.
like biopsy?
No biopsies. Yeah.
I'm assuming those might have been patients were ones that did not have prior augmentation.
No.
They were not having.
Yeah.
It sounds like they were waiting.
Yeah. There's one study that looked at people that had prior augmentation cystoplasty in like 5 patients. It was very sketchy, but, you know, they said they were able to improve emptying. Their whole process of doing the paper, I didn't include it because it was just very sketchy how they described it, what they did.
What about, is there many studies looking at decreased urinary tract infection?
Yes, I didn't include that in there, but those studies on the neurogenic bladders, they looked at decrease in infections, and there was a significant decrease in infections as well, which is very important for this population because of damage to the renal units. That's a good question. Since I've been here, seen 3 erosions of the battery, one in a wheelchair-bound patient who's just bed-bound, and the other 2, I don't know what happened, but they were not mine. Could have been superficially placed. The bed-bound patient was sitting right where she would be sitting all day. And so, yeah, you have to consider that. I usually try to place it right below the belt line so it doesn't get upset. They don't get upset by, you know, putting the belt around it. And sometimes, you know, I consider the patient's dexterity to their left-handed or right-handed. I put it on the side as a favor. And now with the rechargeable units, you obviously want to put it on the side that if they're right-handed, you want to put it close to them on the right side.
Put it in the flanker, would that have
It'll be too superficial. You need that extra fat covering, you know, and that's on the buttock. Thankfully, with the new IPGs and the small profile in much thinner patients, which have classically been a problem, we can actually put it just subcutaneous now, and it's okay. All right, thank you all.
So everybody knows we're resident down this week.
It's gonna be tough. Yeah.
Did you get that slide?
Which one?
Your very first one.
When I first started here, I gave a lecture. They sent it to me. I think Stacy sent it to me.
Do we have like a,
Yes, there's an Erlanger template, there's also a UT template.
Yeah.
what should we be using? For instance, comes out with this, like,
Well, I made my own UT, like Erlanger ones and UT Men's Health ones, and just changed it to UT Men's Health. So you do UT pediatric neurology.
Right, so do you have, like, I guess my question is, where do I get that? I think.
There's
it'd
an
be nice
Erlanger,
if we
there's an
just-
Erlanger template if you want. And then there's a UT template that Stacy just sent me. If you want UT check, you go to our UT.
I just think we gotta standardize it for Grandrounds, whatever, but like for meetings and stuff, yeah, we have.
You're all pretty ugly.
Well, so this is where I'm going, like maybe we should like.
I think, yeah, I think Stacy gave me that one. Do you like that one?
The
Well,
UT
I like
Erlanger has the
the
best
logo.
color profile. UT Erlanger one has like the best color profile, like the blue.
Yeah.
All the other ones are like green and orange. And those look bad.
I think we ought to make one that we just say every time a resident presents, just so it's like Korean.
Yeah, I think you do the UT Erlanger one. And then honestly, we just ask marketing just to have like UT